So, for those who don't know who I am, my name is Anthony Carr. I'm the present chairman of PWSAI. And as I always say, I'm more importantly the father of a little girl, Lauren, who's 6-year-old, who's got PWS. So, without delaying any further, I'd just like to introduce the first speaker of the afternoon, who's June Ann Gold. June is a clinical geneticist who originally trained in St. Bart's and the Royal London Hospital. She's particularly interested in rare disorders. She's also passionate about the difficulties faced by those with PWS and their families. June Ann is now working as an associate professor in pediatrics in the Division of Genetics in Loma Linda University Medical Centre, CA. June Ann is currently setting up a team-centred clinic for adults with PWS. She's a member of the board at IPSO and PWCF. Today, June Ann will talk about the genetics of Prader-Willi syndrome.
Good afternoon. Oh, you've done good. I don't have a voice. For those of you who know me, I don't very often have a voice. I have a vocal cord palsy, so I apologise, but they seem to be doing a great job. Can you all hear me at the back? Great. Okay, so my title today is Understanding the Genetics of Prader-Willi, and I think that's a very dry and difficult thing to do after lunch, but I'll do my best. So to start with, I thought I'd just show you the two places I actually work in California. I trained in England as a pediatrician and a geneticist, clinical geneticist, and then when I moved to the US, I retrained in genetics. So I often say to people, you're getting twice the training for one person. This is the University of California, Irvine. It's based just near Newport Beach, so you can see why someone from London and the rain would move to California. And that's where I do my Prader-Willi research, because Dr. Cassidy was there as the chief of genetics prior to me going there. But I have had the privilege of being able to help with some of the evaluation and looking and encouraging people to research into the data that she collected over many, many years. And here is Loma Linda. It's in the Inland Empire. It's not a particularly nice place to live or work, people say, but there is a wealth of medical problems, including a lot of individuals with Prader-Willi who come to me there. And its main claim to fame is that in 1984 they put a baboon into an infant's and a baboon's heart, into an infant's. And now they've got one of the biggest infant heart transplant programs in the US. So I have the privilege of working there. I'm going to talk a little bit about basic inheritance. I know that I'm talking mostly to families, so I apologize to those that are care providers, that I'm going to keep it at a very basic level, as that's what I was asked to do. And so I'll talk a little bit about chromosomes, about chromosome 15 itself, and the region where the Prader-Willi problem is. A little bit of an overview of imprinting and how that relates to Prader-Willi and why we get the problems that we do in the region. A little bit about risks to future children of individuals who have one child with Prader-Willi. And then I'm going to be different than all the other speakers because everyone else has been doing the questions at the end. I've tried to shorten my talk to give you some time for questions because my dad's 84th birthday today, and I'm taking the opportunity to fly back to England to be with him for the evening. So I've got no conflicts of interest apart from being on the board of IPSU and also the board of Prader-Willi California Foundation. And I just have to say thank you so much for inviting me to speak today and for all your organisation and encouragement. So now we get to the boring stuff. Chromosomes, actually, people think, like Prader-Willi, that they were discovered in a very much the same era. And the total number of chromosomes that we all talk about now is 46 in individuals, 23 from their mum, 23 from their dad. And it wasn't until 1956 that we actually knew the correct number. Prior to that, it had always been described as being 48, even though when you go back and look at the papers who wrote those individuals wrote, they actually, you could only see and count 46, but they still, because it had been 48 and the literature continued it on. And we know that the center is called the centromere, the telomeres are just the ends, and then the little arm, I think there was a French gentleman in the audience, it started as being called the P because it was petite and meant small, and Q is the next letter in the alphabet. It's just as simple as that, nothing more clever. So I think I've mainly talked about this, about the correct number. Chromosome disorders can be due to a loss or gain of part of the chromosome material, and that's whether or not you can see it on a simple chromosome test or whether or not you need a more definitive test to actually prove that it is missing. Just a little bit of, I find interesting is that they were then numbered in size order. So they go from number 1 being the largest to number 22 being the smallest. Actually, 21 is the smallest. But it was numbered that way in 1956, and all the papers since would be obsolete if you didn't talk about that. This is busy for some, but I just thought it just takes a chromosome, shows you being unraveled. You can see the double helix of the DNA, and that this then, what we call get transcribes and processed and eventually translated into a protein. And that happens for a single gene. And then we can talk about a little bit what happens when it's not being transcribed and not being processed. Sorry, you've got my talking speed. There we go. So here you can see that if it's unraveled, the DNA actually has a code. And the code is chopped up into pieces that are coding regions and non-coding regions, the introns, which is the stuff or information in between, and the exons, which are the parts that actually give the code and make up the protein. And you can see how this goes up and then ends up with a protein. I know this is complex, but it just gives you a little bit of information to start with. So how does this translate into Prader-Willi syndrome? We know that 70% of individuals with Prader-Willi syndrome have what I try and say to parents is the non-inherited form. It's genetic, but it's not actually necessarily being passed on. And that's the type that has the microdeletion. It's on the paternal copy of the chromosome 15, and it's in this region. There are 2 classifications of types of deletion, the type 1, and the type 2 deletion. And I'm going to show you this on this complicated. This is why I wanted to show you what a chromosome was first. So you can see here that an individual who has a piece missing from the whole of this region, from the top to the breakpoint 3, as we call it, is the type 1 deletion. So they're missing more of the region than those that have the type 2 deletion. And about 40% of individuals have the type 1, so that's 40% of those 70%. And the remaining 60% probably have the type 2. I'm going to talk a little bit about epigenetics and what imprinting means, but just to say from this part, you can see the genes that are in green are the ones that are expressed on both chromosomes, the one that comes from mum and the one that comes from dad. Whereas the ones that are just expressed on the ones that just come from dad are in blue, and the maternally expressed genes are the ones in red. We sometimes talk about the larger type deletion, the type 1 having more clinical problems sometimes than the type 2, particularly in the obsessive-compulsive disorders, sometimes more self-injurious, and sometimes the academic performance is slightly less. So let's talk about the difference. This is a normal maternal chromosome 15. This is the chromosome 15 with the microdeletion. On the long arm, the cubit of the chromosome, you can see it's just a little bit shorter here. You can see this band here is present, but this one is not. And that's where what we mean by a paternal deletion of chromosome 15. And this is just showing you how we used to see chromosomes some time ago. Sometimes it's visible, sometimes, and these are a pair. You can see this one is slightly longer than this one. But it wasn't always possible to see it, and some individuals will have a smaller deletion and sometimes are not seen on chromosome testing. So that's why the testing for Prader-Willi now, the first line of testing is usually methylation to look and pick up about 99% of cases. I'm ahead of myself. So the drawback of methylation is that it does pick up all those, or mostly all those apart from 1% that have Prader-Willi. But it doesn't tell you which molecular type it is. So then you need to go on and look and see which type. Is it a deletion, or is it some of the other mechanisms that I'm going to talk about? So usually what most physicians will do is then go on and test with a test called FISH, which I'm sure parents come to me knowing whether or not they've had FISH testing, but most don't know what FISH actually means. If it's positive, we know that's a deletion in the region. It doesn't tell us which deletion necessarily. And if it's negative, then it's likely to be uniparental disomy, which I'm going to talk about in a second. And then you can go on and do further testing. nowadays, dependent on where you are in the world, people are doing something called a microarray test and may not have actually had the chromosome analysis first and then FISH. I more than often get called to our neonatal intensive care unit to a floppy baby who's having difficulties feeding. And I'll go and see them, and they may have been there for a day before they've thought to call me, and they've already sent the microarray test. And if it's in the process and being sent, then I leave it be and I get the result from that. And that's very informative about the breakpoints of where the deletion would be if it's the deletion. So this is just a quick slide to show you FISH stands for fluorescence in situ hybridization. It's a long name, so FISH is much more preferable, I'm sure, for most of you, including me. And basically what we do, or what the clever people in the labs do, I'm not a laboratory person, is they break up the DNA, they put a fluorescent marker on the different strands of the DNA, and then they can see it fluoresce, and if it's there, then it's not deleted. So I mentioned the words UPD, or uniparental disomy. I think before we talk about what that is, we need to just mention that it's due to epigenetic effects. So it's a characterization or characteristic of cell-to-cell propagation by means of other influences which make them different than classical Mendelian inheritance, whereby just one gene is affected. And this means that some genes can be switched off, which I showed you in that chromosome 15, that some regions can be switched off in some, on one side, one chromosome to the other, and it's dependent on the parents of origin. So usually one of the things we talk about is something called methylation, and methylation kind of attaches itself to the gene, and I liken it for parents that actually it's like a little blanket around that gene and stops it working. So if one of them's turned off and the other gene is working, and in Prader-Willi's case it would be the paternal copy, you can suddenly understand that actually if that other copy is missing, then you've got no working copy. And that's what we're finding is the problem with Prader-Willi. But it's not one single gene, it's the genes in the region. So this is just summarizing a little bit about, here you can see the little green light here shows that that's the part that's actually active and working in Prader-Willi. And obviously both parents would have a parental and paternal and a maternal copy. And here you can see as the maternal copy is switched off. So it's epigenetically modified. So you can see in the 70% that have the paternal deletion, they've got nothing working here and nothing here. The other way we can get Prader-Willi is by gaining 2 copies of our chromosomes from our mother. And I will show one slide where it shows you a little bit how you can get that. But you can see that if both of your copies of it come from your mother, then you've got no paternal copy that's working. And then the other way is that I actually would like to be able to have the technical knowledge to be able to change this, because it basically is coming from the father, but it's probably the father's mother's copy. And we switch our chromosomes to being paternal or maternal, because obviously we all have one copy of each. So when it's passed on from the father, it would switch to being the father's copy. But in the imprinting defects, the switch doesn't happen. And the chromosome then behaves as if it was still his mother's copy, so it looks like it's a maternal copy. So it's still methylated, and the genes are switched off. And here we have the 4% unknown. It depends which papers you read and whether or not these truly are Prader-Willi, or whether there is truly as yet an unknown genetic cause for Prader-Willi. Is everybody with me so far? And I don't mind if anybody wants to interrupt me, that's fine too. So here, just talking about uniparental disomy, you can see that there's 2 copies are passed from mum, so you end up 2 copies of mum. And all uniparental disomy means is that it's just come from one parent. And here is what you would expect in a normal individual. And this is paternal UPD, which is seen in another condition some of you will have heard of, Angelman. So inheritance of both chromosomes of a homolog is one same chromosome. So both chromosome 15s come from one parent, and in Prader-Willi's case, it's from the mum. So the imprinting is the genomic effect, the effect of having the chromosome region imprinted and methylated, and therefore in the maternal copy, the genes are switched off, and it depends whether it comes from mum or dad, and in this region, it's switched off in the mum. This actually change and switching off happens just at the formation of the egg and the sperm, and that mechanism of switching off and methylating the parent's DNA changes at that point. I think I've made my point about that. So here you can see you've got 2 normal maternal copies, but because they're both switched off and functioning as they should be as one chromosome, they're therefore going to be switched off and not functioning as they should in the individual with UPD. This is another schematic way of showing it. It also shows the imprinting region. You don't need to look at this at the bottom, but it was all in one. It came from a paper. I think it was one Dr. Cassidy wrote. So here you can see the paternal deletion, the maternal methylated region. Therefore, this individual has Prader-Willi. Here, you've got 2 methylated maternal copies, UPD, therefore the individual has Prader-Willi. And here, the imprinting defect, which means that this paternal copy actually is functioning methylated as a maternal copy. So therefore, the individual has Prader-Willi. This is the busy slide. I couldn't find anything better to use. And sorry. So here you can see these are eggs and sperm, if you like. Here is the fertilized ovum, and then the individual. And you can see in a normal individual it's one of each copy, a male and a female one. Whereas in this one, sometimes what happens, the placenta doesn't behave like the individual that's eventually born. Sometimes we see an extra chromosome in the placenta, and then this gets rescued, but sometimes the one that's rescued may be the paternal one, or it could be the maternal, and then you can see how you end up with this. Sometimes you end up with none in one, and it goes down, you end up with UPD. And the same, sometimes there's just one in a, and then because no extra one comes along, it duplicates itself. So it's again the same thing. And this is just showing it, how it happens, that you get an extra one and it's rescued. These don't go on and live, but then this does, and you end up with the 2 same copies. The imprinting center defect, I think I went into that quite a lot, that it doesn't then behave like the paternal copy that it should do. It continues to behave as the parents of origin that it came from. So there are other syndromes that have imprinting as part of them. Many of them, apart from Angelman, actually also to do with growth and development. And this particular one is to do with being overly small rather than overgrowth. So in summary, I'm giving you, I got my 10 minutes, and as I wanted to give you 10 minutes for questions, I shall just finish up. There's lots of information here. I think in summary, there's 3 main mechanisms: deletion, the UPD, and the imprinting center defect. There's usually a very low risk of recurrence. Sometimes we give 1 to 3%, depending whether you're in Europe or the US, for something called gonadal mosaicism, which means that they are just in the cells of the eggs or the sperm, and unless there's an imprinting center defect, that's the one that people need to know about the recurrence risk, because it doesn't switch. They have a 1 in 2 risk of having another affected child, or a 50% risk. Any questions?